Hello, today we'll be discussing gestational trophoblastic disease, and this is a group of diseases that come about because of abnormal proliferation of the placental tissue. These gestational trophoblastic diseases can be classified into four major categories. We have the molar pregnancies, which are the majority that we see, 80%. We have the persistent or the invasive moles, the choriocarcinoma, and the placental site trophoblastic tumor. The placental site trophoblastic tumor is quite rare. These diseases can also be classified into benign and into malignant. The benign ones are the molar pregnancies, which are the complete mole and the partial mole. The malignant ones are the persistent or invasive mole, the choriocarcinoma, and the placental site trophoblastic tumor. All of these tumors have the unique ability to produce human chorionic gonadotropin. So this human chorionic gonadotropin serves as a tumor marker. We use it for diagnosis, and we use it to monitor the treatment. All these tumors again are extremely sensitive to chemotherapy. So if you compare to other gynecological cancers, the cure rate for gestational trophoblastic neoplasias is very high, especially if you get it early. The common risk factors associated, these are not causal factors, really those that are associated with the gestational trophoblastic neoplasia include extremes in age, someone who's had a history of gestational trophoblastic disease, nulliparity, diet low in fat, folic acid, and other factors such as smoking, infertility, abortions, and use of contraceptives. So the benign ones, like we mentioned, the molar pregnancies can either be complete or incomplete. So how does the complete mole come about? Well, it comes about when there's a normal sperm that fertilizes an empty egg. You get a 46XX that duplicates into 46XX, of course, and 46XX. And the partial mole is formed when you get two sperms fertilizing a normal egg. So what you end up with after the duplication is 69XXY. These are the most common variants. There could be other variants, but the ones that we've mentioned are the most common variants. Other differences between a complete mole and the partial mole. We've already talked about the karyotype. We can also talk about the chromosomal origin. In a complete mole, all the chromosomes come from they are paternally derived. They come from the father. And in the partial mole, there's only an extra paternal set. In a complete mole, there could be in a complete mole, there isn't any fetal tissue. In a partial mole, there may be a coexistent fetus. So when you look at the signs and symptoms in a complete mole, you get abnormal vaginal bleeding. But in a partial mole, you get features of a missed abortion. The classic symptoms such as hyperemesis, hypertension, hyperthyroidism are common in a complete mole. These may not be very common in a partial mole. In a complete mole, you get the uterine size that is large for dates. In a partial mole, the uterine size is usually equal for dates. Same thing as you see in a missed abortion. You know, when you have a missed abortion, the uterine size may be equal for dates. Then you get these thicker lutein cysts, especially in complete Mohs. These thicker lutein cysts come because of overproduction of beta HCG. Remember that beta HCG has got the same chemical structure as these hormones that come from the pituitary, such as LH and FSH. They've got almost the same chemical structure. They are, analogs, so to say. So once there's a lot of beta HCG, there is also a release of luteinizing hormone and the FSH, follicle stimulating hormones, that may stimulate the ovaries, producing these exaggerated thicker lutein cysts. In a complete Mohs, since you've got much more beta HCG release than in a partial Mohs, you get the likelihood of getting the thicker lutein cysts more. Other differences include the possibility of metastatic disease. In a complete Mohs, you have a 4% chance of getting metastatic disease. In a partial Mohs, you've a 0% chance of getting metastatic disease. So how do you make a diagnosis? How do you evaluate for a diagnosis? So of course the first one is a beta HCG, which in all molar pregnancies is very high. And if you go ahead to do your ultrasound, you get the classic snowstorm appearance. On your ultrasound also, you get these huge cysts, thicker lutein cysts. So when you get a woman with a molar pregnancy and you do a scan, you find that she's got huge bilateral cysts. Sometimes it could be an unilateral. Do not rush to take them to theater to remove the cysts. As we have said, these come about because of raised beta HCG, which has brought about raised luteinizing hormone and follicle stimulating hormone. Once you treat, you evacuate your molar pregnancy and the beta HCG goes down, these cysts will resolve on their own. These cysts, you may also see them in pregnancy, because in pregnancy also in the early stages, there's a lot of luteinizing hormone. So you may get these cysts. Again, in pregnancy, you are strongly advised against operating a woman to go and remove cysts, because in fact she may lose the pregnancy because the cyst may be supplying some progesterone that is important to keep the pregnancy from coming out. Generally in young women, let's say between 18 and 35, generally in young women, if you find cysts, usually they are a result of normal menstrual cycles. Generally within 3 menstrual cycles, the cysts would have resolved on their own, especially if they're less than 6 centimeters, 5 centimeters. There is no need for you to rush to take young women to theater and go and remove cysts. So in your evaluation for a molar pregnancy, you should also do an X-ray, a chest X-ray. If there is metastasis, you may see these cannonballs. You may see these cannonballs. If in a molar pregnancy you do an X-ray and you see cannonballs, it is a sign of metastasis. So in that case, it is not a benign molar pregnancy. It is probably a choriocarcinoma. Most of the time we don't do it because, we don't see choriocarcinomas as often as we see the normal molar pregnancies. But it is advisable because sometimes you may not know that what you have is a choriocarcinoma. The reason is that the treatment for any molar pregnancy is for us to take her to theater, and usually she goes under anesthesia. If she's got these things in the lungs, your anesthetist will struggle to keep the patient oxygenated, because these will be giving difficulties with breathing. So it may seem trivial, but at the time that you take her to theater and she's got these, you may struggle. So now, this is what they look like after you've done your evacuation. This is what it looks like, the vesicles, the classical vesicles. Sometimes you may have a molar pregnancy and a normal pregnancy in the same gestation. And at such a time, you may get an opportunity to see the difference between a molar pregnancy here on your left, a complete mole, a placenta of a complete mole, which looks unhealthy, with some vesicles there, and a placenta of a normal pregnancy, which looks healthy. This is just to show you a comparison between the two. Molar pregnancies should be differentiated, especially with multiple pregnancies. This condition where you get a lot of placenta, huge placenta, multiple pregnancies, infections, fibroids, threatened abortions, and ectopic pregnancies, even normal pregnancies. The treatment of molar pregnancies is to take the woman to theater, because these women bleed a lot. There's a lot of placenta there and it bleeds. Yeah, this is one of the conditions that when you see it, you won't forget, because of the amount of bleeding that you see. 2 liters, 3 liters. So your suction curettage must be done in theater. And of course, because you anticipate bleeding, you should have your IV access, you should have your full blood count, you should have your grouping and your cross match. Then after you finish your evacuation, you give oxytocin. It is discouraged to give oxytocin during the evacuation because of a small possibility of thromboembolism. In rare cases where you have failed to control the bleeding, rare, very rare, you may end up with a hysterectomy. But this is not common. Follow-up of these cases is very important, because most molar pregnancies, well, not most of them, some molar pregnancies may end up becoming malignancies. So you need to follow up, so that you catch the malignancy early and start treatment. So the follow-up will consist of, after you've done your evacuation, 48 hours, you do your beta HCG weekly for 3 consecutive weeks. Then after that, you do it every month for 6 months. If your beta HCG remains the same or it starts going up, then there could be a problem. You could be having an invasive mole or a persistent mole. During the time that you are following her up, remember that you don't want her to get pregnant. So contraceptives of choice are the oral contraceptive pills. For those that are very motivated, for those that are well motivated, you can even recommend condoms. But generally, we recommend oral contraceptives. You avoid the intrauterine device. Whether it's Mirena or Copper T, you avoid those. Because if there is a persistent or invasive mole and you put a Copper T there, you're going to perforate. There's a huge chance of perforation. Then you also avoid the progesterone-based contraceptives, because they are notorious for bleeding on their own. So you want to know if the bleeding that you have is from the contraceptive or is from a persistent mole. And of course, for the pregnancies that come, subsequent pregnancies, they should be closely followed up. One more thing that I want to mention on the follow-up, which is important. As you've seen here, we're talking about doing monthly beta HCG for 6 months. In our environment, that may not be feasible because beta HCG is expensive. Sometimes it, 300. So 300 every month may be too much. So if you are in an area where you can't do beta HCGs every month, then just do a normal pregnancy test. A normal pregnancy test will give you a rough guide of where the beta HCG is. So now we go to the malignant ones. Like we said, they're divided into 3 types. There's the persistent mole, the choreo, and the placentocyte trophoblastic tumor. In 50% of the cases, the malignant tumors, they happen months to years after a molar pregnancy. In another 25% of the cases, they happen after a normal pregnancy. And in another 25, they happen after a miscarriage, an ectopic, or an abortion. So the form of monitoring is the same with the monitoring, and diagnosis is the same with beta HCG. Surgery rarely has a role except for placentocyte trophoblastic tumor. So the invasive mole, they almost always happen after you've done an evacuation of a molar pregnancy, which is important that you follow up a molar pregnancy so you don't end up with an invasive mole. So what happens with an invasive mole is that the placental tissue penetrates through the myometrium. At times it may rupture the myometrium, and so you get bleeding into the abdomen. This is quite a disturbing picture if you see it. So this is a patient who had persistently rising or plateauing levels of HCG after a molar pregnancy evacuation, but there wasn't adequate follow-up. The most common symptom, of course, is abnormal bleeding. HCG and ultrasound are the cornerstone of diagnosis. So for the low risk patients, we'll discuss very soon which patient is low risk and which one is high risk. For the low risk patients, you give them single agent chemotherapy, and for the high risk, you treat with multi-agent chemotherapy. Choriocarcinoma, this is a necrotizing tumor. It can happen weeks to years after any type of pregnancy. It can be a normal pregnancy, it can be a molar pregnancy, or it can be a miscarriage or an ectopic pregnancy. Any type of pregnancy can result in a choriocarcinoma. These are metastatic, and they spread to the lungs, the vagina, the brain, the liver, the kidneys, the intestines, and so on. When it spreads to the lungs, you get cough, dyspnea, and other respiratory symptoms. When it spreads to the brain, you may get headaches, dizziness, blackouts, or any lesions that, or any symptoms that may mean that someone has got a space-occupying lesion. So, in this one also, there is one that has got good prognosis and one that has got bad prognosis, or low risk and high risk. For those with low risk, you can treat with single agent chemotherapy. Those with high risk, you treat with multi-agent chemotherapy. Then the placentocyte trophoblastic tumor. These are rare. And what is different about these is that they produce a lot of human placental lactogen. So in these ones, remember, it is not human chorionic gonadotropin, it's human placental lactogen. So that is the one that we use for diagnosis, and the treatment for this one is hysterectomy. It is not sensitive to chemotherapy. So we talked about low risk and high risk. How do we know which one is low risk and how do we know which one is high risk? Remember, for those that are low risk, we give single agent chemotherapy. Those that are high risk, we give multi-agent. This is important because you may be in a rural area and your patient may not be able to move from a rural area up to Lusaka to CDH. So you need to know if you can help or you just refer directly. So these are the parameters that are used for you to decide whether it's low risk or high risk. You look at the age, the antecedent pregnancy, the interval between the pregnancy event and the treatment, the beta HCG at the beginning, the number of mets, the site of the mets, the largest tumor, including the uterus, and the number of failed chemotherapy drugs. So each of them has got a score. So for example, if a woman is less than 39, she scores a 0. If this same woman, this same woman had an abortion before you made a diagnosis of a choreo, if she had an abortion, she scores a 1. If the beta HCG was less than 1,000, she scores a 0. So you keep on scoring until you reach the end, until you reach the number of failed chemotherapy drugs. If your score is less than 4, as in 1 to 4, that one is low risk, so you can use single agent chemotherapy. But if your score is between 5 and 7, that is medium risk. And if it is above 7, above 8, that is high risk. For medium risk and high risk, you use a multi-agent chemotherapy. The drugs that are used in single agent chemotherapy is methotrexate, and the drugs that are used in multi-agent, I use I'm not the one who uses it, but there's a common mnemonic that we use known as EMACO. A, which is E, EMACO is etoposide, methotrexate, actinomycin D, cyclophosphamide, and oncovin. Oncovin is also known as vincristine. So if you're going to use multi-agent, you're going to use the combination of those drugs. If you're going to use single agent, you just use the methotrexate. So that is what I had in this tutorial on gestational trophoblastic disease. Thanks very much for listening, and I hope to see you on the next one.